Now, moving on to our first section, that is the lesions of the spinal cord. So, what could affect spinal cord? As you know, the spinal cord is actually covered or encased by a vertebral cage, but one thing would be high energy trauma, which can lead to the fracture of the vertebral bodies and these vertebrae, and eventually damaging the spinal cord, or this could be some kind of a tumor. So in this section, we'll be briefly discussing what are the features of if there is associated spinal cord injury, how to diagnose it, how to manage it, and what are the different complications associated with spinal cord injuries. So before moving on to injuries, we have to know what are the main tracts which are actually passing through the spinal cord. Although there are multiple other tracts, but the main three are of the utmost importance. These include the corticospinal tract, which is actually the motor tract or called the pyramidal tract. This starts right from the motor cortex in the cerebrum and all the way back into the spinal cord, where it anastomoses and then comes out of the spinal cord in form of motor nerves, which is actually the main tract which is controlling the motor function of the body. So it is lying anteriorly in the spine. It's also called as anterior corticospinal tracts. Carries the motor neuron, as I just told you, and usually lies in the interior horn or interior columns of the spinal cord. The next is spinothalamic tract. This is also a sensory tract. It actually carries pain, touch, and temperature. But the important point is that usually, as this is coming in, it is actually decassetting to the other side. So if for any reason this tract is damaged at this point, then it will not cause the loss of pain, touch, and temperature on this side, rather of the contralateral side. And that is something we will see when we are dealing with Brown-Sequard syndrome. Another sensory tract, which is also very utmost important, is the posterior column tract. This is actually coming all the way from the cerebellum. It's actually going all the way up to the cerebrum, and it's actually carrying the sensation of it's deep sensation, deep touch, light touch, and all this. And there are two main sensory tracts, which is the spinothalamic tract and the posterior column tract, and one is the motor tract, that is the corticospinal tract. Now, what would be the clinical features? Usually, depending upon where the issue is, it could be an upper motor neuron lesion or it could be a lower motor neuron lesion. Usually, it's an upper motor neuron lesion. If spinal cord gets damaged higher up, then usually leads to spastic paraplegia or paresis, in which the muscle there's hypertonicity and spastic paralysis of the muscle. For example, if extradural compression lesions are causing symptoms, this could be they could be having secondary to extradural hematoma in the brain, which could be causing classical upper motor neuron lesions, or this could be post spinal surgery, or post if there was for any reason spinal anesthesia was given, may result in some kind of epidural hematoma. Then this may be causing some kind of a lower motor neuron lesions, not the classical presentation of upper motor neuron lesions. It could be one of the most, as it's controlling the motor and sensory function. So usually the weakness and numbness is the first thing which comes up. Other features include if it's something is compressing from inside or from outside, which eventually results in cervical cord compression syndrome. This results in classically upper motor neuron lesions, usually resulting in spastic paralysis of lower limbs. Or if of the lower motor neuron lesions are involved, in which there is a flaccid paralysis of the upper limb. There is a syndrome called as central cord syndrome. If you see the spinal cord in a cut section, it has actually inside there is a gray matter and white matter is lying outside. This gray matter mainly contains the nuclei of the corticospinal tract, where they're synapsing and affecting it. So if for any reason this central cord area is affected, for example the blood supply to that central cord is actually compromised, then these cells which are lying in the center of the spinal cord will get necrosed or will lose their function, resulting in motor paralysis, which is more pronounced than sensory. But that does not mean that there is no associated problems. That is classically termed as central cord syndrome, because it affects the upper limbs more than the lower limbs. But they may be associated with altered bowel and bladder function, and maybe altered pain sensation as well. Then, if it's a thoracic cord compression, usually it's more, although there's a variable sensory loss because when these sensory fibers which are ascending from this through the spinal cord, they may be decussating, and there may be internunical neurons which are interconnecting these as well. Therefore, usually sometimes the loss is variable. There may be a dermatomal loss, but they may not be present as well. But mainly it causes upper motor neuron lesions. Now, if the lumbar cord is compromised, depending upon where the injury is, usually it causes conus medullaris or cauda equina, or it can cause both. In cauda equina, this is actually it's one of the surgical emergencies in spine, that this results in pain which is usually radiating to both legs with saddle side paresthesia around the anus and the urogenital structures, along with severe sudden weakness and of the both limbs. This may be insidious, maybe due to some kind of a pathology, or it may be acute compression. Sometimes this is associated with upper motor neuron or sometimes with lower motor neuron lesions. A usually classical example in the lumbar, if there is lumbar compression, is cauda equina syndrome. Then their other clinical features may include ipsilateral upper motor neuron weakness, which is usually as posterior column is not decussating to the opposite side. Therefore, if for any reason posterior column is dysfunctioning or it is affected, this will result in the loss of light touch vibratory sense of the same side of the body. And this usually, as it's a sensory tract, it does not cause any motor weakness, but there is usually associated with sensory loss of the body. So if a patient comes to you, if there is no evident history, one thing is how to diagnose it, and diagnosis will be depending upon, it always starts with the history. If this could be a history of high energy trauma, there could be a history of some kind of a febrile illness, there is some kind of a stab to the area which can affect them, or this could be simply a history of some kind of a tumor, weight loss, or anything. So once history and examination has been done, then we probably move on to the X-rays and MRI. X-rays are actually could be good in case of acute settings, that usually the dislocation, the fractures can be easily picked. But not always it's associated with some kind of fracture. Sometimes there could be only ligamentous injury, or there could be only cord compression without any evidence of change of problems on the X-rays. Then you need an MRI. MRI is good enough that it not only picks where exactly is the problem and what kind of a lesion is this, whether it's something else is coming and compressing the spinal cord from outside, or is it due to edema of the spinal cord, or due to some kind of a herniation of the disc which is actually compressing the spinal cord. That is going to rule out what is exactly the etiology or pathology behind the spinal cord compression. Then if there is no associated trauma and there is some kind of a febrile illness, and we are suspecting if there's meningitis, or even in case of a severe form of meningitis, this may be associated with paralysis or paresis, then yes, we need blood tests. TSF examination may be required, especially in children. The gold standard is gadolinium based, which is an extra amount of this gadolinium based MRI, which can help us to delineate exact pathology and to be sure about the diagnosis. Once diagnosis or differential is made, then we can proceed to the treatment. So what could be wrong with the spine? It could be an acute compressive lesion. There may be history of it, in which classical example is cauda equina syndrome, in which there's an urgent diagnosis and treatment is required, and usually associated with bladder dysfunction. This may be, once the decompression is done, there may be improved function, well, for motor as well, bladder function may be restored as well, and there may be no associated saddle anesthesia. Now, in case of epidural, if it's an epidural abscess, it's a surgical emergency. It can present with acute pain and muscle spasm. There may be leukocytosis, elevation of ESR and CRP. Therefore, as it's an abscess and present in the epidural cavity, that has to be drained. And usually decompression along with the antibiotics is the treatment of choice. This could be acute disc prolapse, For example, patient comes to you and says he or she was lifting some kind of a weight, and after that it was a sudden shooting and stabbing kind of a pain which started in the lower back, and now it's radiating towards this leg. Then most likely it could be an acute disc prolapse, or it could be a chronic disc prolapse. If it comes out to be an acute disc prolapse, these patients will usually have a unilateral symptom, highly unlikely to have a bilateral, but still bilateral symptoms can be present as well. Usually, if it's in the lumbosacral region, this could present in the form of a corda syndrome, and acute discectomy may be required at times because it may be compressing the spinal cord so that to prevent a permanent damage in these patients. Or it could be chronic discogenic pain. For example, there was some injury, he took some medication, some rest was there, but then as the activities of daily living have been carried out, this is associated with muscle spasm, low back pain, and actually this back pain has now started hampering the patient's daily life. And there is maybe in this whole episode maybe would have occurred around after 3-4 months, 6 months, 1 year time. Usually it's associated with narrowing of intervertebral foramina, because once there's always element of osteoporosis in these patients, this foramina usually get compressed, and they compress the exiting nerve root, leading to this kind of symptoms. There may be radiculopathy once that starts compressing the nerves, or once the muscle gets affected, there may be associated myelopathy as well. Diagnosis, usually x-rays are normal. Sometimes they do show osteopenia, generalized muscle straightening of the spine may be visible with muscle spans, but the ideal diagnosis is made on MRI, in which the chronic disc may be compressing the spinal cord can be seen. Treatment, usually it could be laminectomy. Usually operative treatment has to be done. Sometimes fusion may also be required, depending upon what is the amount of injury and what is the amount of prolapse which is actually seen on MRI. It could be a vertebral disease as well. Classically, in our part of the world, the more common is tuberculosis. Usually it affects the anterior part of the vertebrae, and patient may be presenting with a chronic long-standing history of weight loss, cough. There may be previous exposure of the tuberculosis as well, and he or she may be living in tuberculosis enriched area or infested area. Therefore, there may be insidious onset of kyphosis. Could be underlying the problem could be due to an abscess which is actually found by the tuberculosis. So it could be either tuberculosis or metastatic disease. Usually once kyphosis occurs, or when this usually presents with cord compression like symptoms. X-ray and needle biopsy may be required, but usually with other associated multiple other tests may have to be performed to rule out whether it's likely metastasis or whether it's likely tuberculosis. If it comes out to be tuberculosis, then usually the treatment of choice is anterior decompression, internal stabilization. Others include spinal cord tumors. Now, there could be multiple others, usually either primary tumors which can affect the other vertebral body, for example, such as histiocytosis or hemangioma. There could be those which are affecting the posterior elements, for example, aneurysmal bone cyst, orthoblastoma, osteoidosteoma. They all could be affecting the posterior elements. Now, not necessarily this is a primary tumor of spine. This could be a secondary mets, which would be coming from anywhere, from the breast, from the lungs, could be from the renal, from the prostate, or from anywhere else. So if it comes out to be spinal cord tumors, if it's a lesion, which most likely predicts like lesion of some kind of a tumor, then it could present either with the narrowing or kind of a point compression symptoms may be present as well. This could be progressive paresis as it continues to impinge on the nerve and leading to these symptoms. There could be bony erosions and widening. There could be flattening of the vertebral pedicles, and usually depending upon whether it's the tumor, which is what kind of tumor it is, and whether it's radio sensitive or radio resistant, or what kind of treatment which we need to be, but usually involves a multimodal therapy. There may be some kind of a fusion or stabilization, or we should be done with the spine along with the excision of the tumor. As I just told you, then more commonly it's always the chronic discogenic pain, usually associated with it could be for any other infection, for example, in syphilis as well, or syringomelia, in which there is a cyst formation in the spine which can enlarge and present with a classical pattern of cord compression. There could be cyst, weakness, and wasting of hand muscles as well if it's presents in the spinal cord, and especially in the cervical area, and this could be leading to destruction of spinothalamic tract. Therefore, the contralateral pain and temperature sensation would be lost. Usually, the treatment is decompression and along with the fusion as well. Sometimes we also be required. So, when we are dealing with spinal cord injury, we on history we need to first rule out what kind of injury it was, what kind of insult it was it traumatic, was it atraumatic? If it was atraumatic, was it acute or chronic? If it's acute, what most likely it could be, or if it was chronic, what was it associated with? What are the symptoms which are coming in as well? How much cord damage could have already occurred before we are examining the patient? Then whether if it's acute traumatic event, then is it associated with spinal cord or not? Usually in the case of an acute trauma, there may be associated spinal cord in which there is a flaccid paralysis of almost all the muscles, and it actually mimics as if there is a complete cord lesion, but usually this regains, the muscles actually regain their function after some time. Plain x-rays and CT may be required. So in case of acute trauma, there could be fracture or dislocation of the vertebrae. There could be special compression fractures of the vertebral body, which could have retropulsed back into the spinal cord, leading to spinal cord injury, which may be only possible on CT, because this 3D CT would actually exactly delineate the anatomy of the fracture and how much actually cord compression is present in there or not. Then initial management is usually, if the patients, these patients with these symptoms really present in the prednisolone can be given, and usually a 30 mg bolus dose is given, and then we can either continue it for 5.4 milligram per kg for either 24 hours or 48 hours, depending upon whether the patient presented within the first 8 hours or after first 8 hours. In case if it's a stable injury, there is no neurological compromise, and spinal cord remains stable, then probably the traction, bed rest, orthosis, these all can be used actually to optimize the recovery for the patient. But if it is causing a canal compromise, if it is causing neurological symptoms, or if it's causing bowel bladder dysfunction, then we probably have to move towards the operative treatment of the spinal cord injury. Unstable injuries, they always need operative decompression and stabilization. In this section, we have gone through general principles of the treatment of the spinal cord injuries. We have to start with the history, whether it is traumatic or atraumatic. Then if it is atraumatic, then whether it's acute or chronic, or if it's traumatic even, then still it's acute or chronic. What was the exactly mechanism of injury? Then we have to assess the dermatomes so that we can work out how much sensory loss is there. And then we have to work on this as well, that how much motor function is possible as well. What is the power of the different functions below the lesion, and where exactly is the lesion? And once we are able to pinpoint what exactly is wrong with them, then we can constitute the treatment. Usually the radiography which is used actually to exactly reach a point diagnosis is X-ray, CT, and MRI. Most gold standard is gadolinium enhanced MRI, and once we know what is the problem with the spinal cord injury, then if it looks like stable injury, there's no neurological compromise, we can manage it conservatively. But if we are suspecting it to be progressive and unstable and causing neurological compromise, then the treatment option includes operative decompression and stabilization. That's it from this now. Thank you very much. Keep watching sqadia.com.